Recording.
Okay, I think we're all.
There's
okay.
3.
Okay. So, Glenn, can you hear me okay? Let me unmute you. You deserve to be unmuted. Okay. There we go. Glenn, you can hear me okay?
Yep, I can hear you. Can you hear me?
I gotcha. Roger that. Okay, so welcome everybody to today's fireside chat. That's what I'm calling it. I don't know if Glenn's actually calling it that.
I put the fire.
Well, I love it. I love it. Epidemiologist Glenn Grossman. Glenn has over 20 years of experience in this field. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years and taught epidemiology and advanced analytics at Duke Medical School and UNC. He has been involved in epidemiology projects with Medicare, Medicaid, Veterans Health Administration, Military Health Service, CDC, and other programs in the United States and outside of the United States. He currently is Senior Director of Outcomes Research and Epidemiology at Novartis, but all views expressed today are completely his own. And my view expressed today is I am very proud to be one of Glenn's little sisters, and we're thrilled to hear what you have to offer today. Just want everybody to know I'm helping Glenn moderate today's session. My name is Rebecca Berman, so if you have a question, you can send it directly to me in the chat box. I have some questions here that folks sent in during the week, so I will add your question to the queue and hopefully we'll get everybody's questions asked. So thank you. Welcome everybody, and thank you. Handing it off to you, Glenn.
Okay, thanks everyone for coming. So, Beck, what's the first question?
Okay, first question is, I heard that remdesivir received an EUA from the FDA. Alphabet soup. What does that mean for us? Can we end the lockdowns now?
Okay, really good question. Yeah, everyone's been looking at the clinical trial for remdesivir for a while because it was one of these early drugs that showed some promise. It was first developed by Gilead looking for Ebola and some other things. And some of the clinical trials have started coming in. Some of them were mixed. Some of them were more positive. So the FDA just gave Gilead an EUA. So this is called an emergency use authorization. So it's not the normal process. And I wouldn't even say it's a back door for getting a drug approved. Rather, we understand that we're under emergency conditions. And so an EUA is given just for the period of the emergency while studies continue going on to see whether we should pursue it. Because based on the sum of evidence in terms of the efficacy and safety, it's more likely than not right now that it can be used. Basically, there were 2 endpoints they were looking at in the study. The first endpoint that was the really important one, that's the reason that the EUA was given, was that it reduced the length of the infection by around 30%. So I think that was like a few days or so that the infection was less. It didn't show any statistical significance yet with death, with mortality. And ultimately, that's what we care most about. I think I had shown you a bunch of weeks ago. Let me come back to what we had mentioned. So basically, one slide that I had shown here is that if you recall, when someone first gets infected, first they have an incubation period where there's no symptoms. Then they start having the early disease where the virus starts replicating. Whether they have symptoms or not, they'll start to have symptoms eventually, or most people who at some point get symptoms will get it within the first week or so. This is the ideal time to start giving an antiviral. The problem is that the virus is replicating before a lot of people have symptoms, and damage is already starting to occur before people have symptoms. And so by the time a lot of people start having symptoms that are severe enough that they would go to the hospital, it's all a lot of the damage has already been done. And so in that sense, then you're first starting to give them an antiviral. But the problem is because so much of the virus is, so much of the damage is done, then you really have to look at immunomodulatory drugs that reduce inflammation, reduce the cytokine storm, and try to prevent further damage. So it's impressive that the antiviral has been shown to have any effect at all in terms of reducing, potentially reducing health outcomes that we're most concerned about. So right now, it does seem like there could be potential. From my perspective, the earlier someone gets treatment, because we know that there's this window of time where an antiviral is really the best intervention before a lot of the structural damage occurs, then the earlier someone gets this drug, the better. The problem is that this drug is not just like something you go to CVS, something you go to the pharmacy and just pick up the drug. This drug has to be administered intravenously. So what does that mean? So a drug that's administered intravenously is typically considered a medically administered drug. It doesn't necessarily have to be done in the hospital. There's infusion clinics. There's a bunch of diseases where this is common. So typically for some of the maybe rheumatoid arthritis diseases, cancer, other types of things, where people don't have to go to an emergency room or a hospital, but they go to an infusion clinic. I don't know how it's going to play out in terms of how people will start getting this drug if it's starting to be used more. But this is not something that people are just going to be able to take at home. So right now, the emergency use is only for the hospital administration among the sickest of the sick patients. However, having said that, now there's something I want you all to do. And so because now we have a drug that can reduce the viral load that has been approved, so it's shown sufficient efficacy. The problem is a lot of people don't even know that they have SARS-CoV-2 because they haven't been tested. And a lot of people might be having physical damage and they don't even have symptoms that tell them that the virus is there. So what do we do? So the first thing I want you to do, or really the only thing right now that's important, is sometime over the next few weeks, before we lift the lockdown, but you don't have to do it today or tomorrow, just sometime over the next few weeks. If you don't already have one, get one of these devices. It's called a pulse oximeter. So basically what it does, you just put it on your finger for like 30 seconds, a minute, I forget exactly. It measures the amount of oxygen in your blood. If your oxygen falls below 95%, then you would immediately want to call your physician and get a SARS-CoV-2 virus test, because this would be the best indicator you have. This device costs around $50, and it would be, for a lot of people, they might not have any other symptom, but testing your blood for the level of oxygen would be one of the earliest signs where you could have this in your house, and you could test yourself maybe once a day in terms of just seeing what your blood level of oxygen looks like. If it falls below, then now we have a treatment. So potentially if you go and get tested and you have a positive test for SARS-CoV-2, then that would mean that you would go and want to maybe start the antiviral treatment, particularly if you were in a high risk category. So for instance, and so among the people who should be getting this device are really people over the age of 65. People under the age of 65, if they're under very high risk, if they have comorbidities or things, then maybe they should be considering it too. Other people should probably not go and get it because there's not really a big need for those people too. But definitely people over this age of 65 should at this point, from my perspective. Obviously, I'm just speaking for myself as an epidemiologist. This is what I want my parents, my family members, and friends to do right now. Because this could be an indicator. You can do this daily. Once you pay the upfront cost of around $50 or so, then you can do this as many times as you want. It'll reassure you if your oxygen level is good that you don't have to worry about anything that day. Don't let your guard down in terms of exposure and stuff. But now at least you have a way. So one thing that we're starting to see, at least is the common perception in hospitals, is that the earlier you treat the disease, the better the health outcomes. So if you identify the oxygen, then that's good.
We have a question. Rachel Scherzer is asking, so if I have one of these devices, should we test regularly because we may not have any other symptoms? Is this something that we should all be doing and just kind of keeping note of?
Yes. So I would do it every day. Again, just for the high risk groups. If you're 30 years old at low risk, there's not really, especially when the level of the virus goes down and it becomes less rare, or rather it becomes more rare, then your chances of having SARS-CoV-2 will drop precipitously. So the benefit of doing it is not really very strong. Among people over the age of 65, get the device. The benefit is potentially better than not doing it. And it really doesn't take much time or effort, so might as well do it. The other thing is that there's been a lot of devices that have flooded the market. Some are better than others and have been validated. I don't know which are better than others. Some of the names that I'm familiar with are Massimo and like just the CVS store brand. I don't really know many others. So that's an open question. You're gonna have to, when you look for one, you're gonna have to find a way to see which is better than others. I can look into it for next week if people want. But there's no urgency right now. If you've been under lockdown, it's not something you need immediately. We're not opening the doors in most states right now. So if we are opening the doors in your state, then this would be something you'd want more rapidly if you're at high risk. But otherwise, it's just recommended because we know that now there is a potential treatment, and so this would be identifying that you might be someone who could benefit from the treatment early would be a good thing. Okay. Oh wait. So the other thing is so I mentioned that it's an infusion drug. Typically, we don't know. It might be used for 5 to 10 days. It's shown similar efficacy at reducing the length of the disease in people so far in 5 days versus 10. And so there's a limited amount of supply out there right now. So physicians are going to try using it for 5. Just because if you use it for 5, then you can treat twice as many people with the same amount of drug. Right now, Gilead is really stepping up here. They've been really great. So apparently they've donated all of their drug that they have existing right now. So they're not even charging a single penny for it in terms of getting it out there. They're ramping up manufacturing, and so this is good. All right, next question.
Okay, next question. Please talk to us about Sweden. Sweden is all over the news, and it's really interesting how they have taken a much different approach than almost every other country we're hearing about. They never instituted a countrywide lockdown like most of us. But the disease isn't spreading out of control, or maybe you can explain what's going on over there. Is there anything we can learn from them to apply here in the US?
So so a lot of people have been looking at Sweden. So if you recall, Italy was one of the first. So the first outbreak was in Wuhan, China, where it was spreading uncontrollably. The first symptom was pneumonia, and that's why we got the name SARS, because we had previously called it severe acute respiratory syndrome. And so again, we saw this pneumonia, and so that's why I consider calling it SARS-CoV-2 again, as the virus, and COVID-19, coronavirus 19 is the disease. And so it was spreading uncontrollably in Wuhan until they did the quarantine there. In Italy, it was also an exponential growth until they did their severe lockdown there. United States similarly, particularly on the West Coast and then in the East Coast where it hit really hard, exponential growth again. And then you can see that it's starting to flatten the curve that we're looking at. Sweden, in contrast, they never had a lockdown the way that we did in these other countries. And yet, although at the very beginning you could see that they were starting to be on an exponential growth trajectory, so they did have limited lockdown. Let me rephrase that. So for instance, they closed universities, they closed high schools, which remain closed to this day. They closed some other portions of society. They did lock down old age homes and nursing homes and stuff like that. So they did have some intervention, but they were much more loose than a lot of other countries were. Restaurants were allowed to remain open and whatnot. And yet, surprisingly, their curve was not an exponential out of control growth curve. It's not flat, but it's not super bad either. And so a lot of people are saying, well, maybe why don't we just behave like Sweden? Like, so why New Jersey, New York City, the rest of the United States, other countries in the world, instead of damaging our economy, why not just do what Sweden's doing and keep things open where we can? And it's a really legitimate question. So let's dig into it a little bit. All right, so first, what's interesting is looking at the death rates. So like their approach, do they have a lot more deaths than we have here? When you look at it in at a normalized basis. So the United States is much bigger than Sweden. And so you can't just look at the total deaths, you have to look at the rate of deaths relative to the size of the population and see if the rate of deaths in Sweden are more than the United States. And sure enough, when you look at the death rate, there are more deaths on a normalized basis in Sweden versus the United States and versus other Nordic countries. So they are seeing more deaths. It is bad. It's not, however, it's the infection is not spreading as crazily bad as it could be. And so we're still looking at it in terms of what they're doing. But when you look, so one explanation for this could be that, well, maybe Sweden is just testing less. And so the reason that their death rate is higher is because if they're testing less, then the more severe cases are the only ones being identified. And so as a result, maybe their death rate seems higher because the denominator is smaller because they're just not testing as many people. But when you look at that, you realize actually Sweden is testing more patients on general than the United States. So that's not a good explanation. So basically, I've been digging into it to try to understand, like, so what's the rationale? There are a couple big names in Sweden and among epidemiologists over there who have been driving this. One of them, Johan, I can't pronounce his last name. I saw an interview with him. I've been reading up on it from some other sources. And there's basically three assumptions that Sweden is making. The first, that's the most important, that's different between us, that's different between Sweden and every other country, is this assumption of inevitability. So Sweden is assuming that no matter what we do, every intervention is going to fail. And so it's going to be inevitable that everyone who will get infected will get infected. And so as a result, because they think it's inevitable, and so what that means in particular is they believe despite our best efforts, test and trace will fail. Despite our best efforts, all vaccines will fail. So maybe it'll take 2 or 3 years to get the vaccine on market or longer, and all of these are going to fail. And they also assume that all treatments will fail. And so if the assumption, so essentially what they're doing is they're making a forecast. They're not modeling it per se and using statistics the same way that some of the other forecast models are doing, but they are making a forecast model that's based on this assumption of inevitability. And so their thinking is, well, you know, if it's going to happen either way, we might as well just try to have a slow burn. So it just let it happen and spread. At some point when everyone has it, or most people have it, or before that, you'll reach some sort of herd immunity, and then it'll be over. And then you can just get back to work and things will be fine. So the sooner you can get to that level, the better in that case, because then you don't shut down the economy, you don't do things, so better to get there sooner. The other thing that was very clear reading into this is that they fear extensive government control. So if you've been looking what's going on around Europe and some other parts of the world with authoritarian governments, that was absolutely part of the interviews, and when you read into what the thinking is in Sweden, that they're worried of setting a precedent for interventions that are very intrusive into people's lives based on what people are seeing around the world. And so that's an assumption that's in their approach. And so what you're seeing then, based on these two things, of this assumption that government control is something that's really, really bad, and we really need to make sure that it's even that they're willing to almost sacrifice some people for the sake of avoiding it. And then this idea of inevitability, where all of our possible interventions will fail. And so in contrast, so it comes to that. So that's why we're looking at here, where Sweden is still managing to have a slow burn. It's a pretty homogenous population in terms of racial distributions and that kind of stuff. And so far they're doing okay. But obviously their death rate is higher than what you would expect. And we don't know yet. Maybe right now there's the open question about reinfection and reactivation, which we can get to later. But so this is their approach that they're doing now. That's the best that we know in terms of what's going on in Sweden. Already, we do know that in New York City, for instance, and in the United States, so in portions of the United States, let's say, the growth rate of the infection and the number of people dying is out of control, or has been out of control, and that's why we had to go under lockdown. Okay, that's enough on Sweden for now.
Thank you. So you mentioned we don't really know exact details about what's going on as far as testing in Sweden. And, you know, shifting back to the US, Sandy Rock asks, until we have a much more full body testing regimen here around our country, can we really be sure that it is safe to open up? That is, we might already genuinely be at that point without knowing it due to the lack of testing. So what are your thoughts on that?
Yeah, that's a really good point. And so there's, as we mentioned previously, there's different types of tests. The two most important types of tests are tests that focus on the virus and trying to find the level of virus around different parts of the body, and then tests that are serological tests, so these antibody tests that look at clinical changes in the body based on the virus that's there. But you're not actually testing the virus in these new tests. You're actually testing the clinical changes in the body themselves, so looking for antibodies, et cetera. And so in the United States, where there hasn't been a lot of widespread testing yet, we can estimate that the lockdowns have really reduced the spread across households because of the lockdown. But within households, we can assume that the spread has been going on during the lockdown. And so that means that if you look at the course of the disease, in most people, it's maybe 1 month, some people longer, in terms of being able to detect viral shedding. We'd expect that if we're under lockdown for maybe 2 months, that a lot of that will already have gone through the households. And so by the time we open up, the thinking would be in most states, I mean, some states in the United States are already starting to think about opening up, but in New Jersey, New York City, at least, where we're not opening up yet, the thinking is that it will just burn out in the households. And so by the time we open up, we'll have a really low threshold. We're almost like resetting the clock on the number of people who are infected in these regions, in these areas. And so to that point, there's an interesting point about this. And so when COVID-19 was first identified, it was a pneumonia disease, because that was the very first thing. People were out of breath, they couldn't catch their breath. And so the pneumonia symptoms were the very first that could be identified. But really, so it's the virus hooks up to these ACE2 receptors. ACE2 receptors are found all over the body, not just in the lungs, but lots of organs throughout the body. And so we can see the lungs really quickly, but there's other things that are happening. There are neurologic symptoms that we're seeing, headache and other symptoms, loss of smell, loss of taste. There's things happening that we don't even know what's going on in the body, just because we don't have a good vision into what's going on. So for instance, within the last week, one thing that's been found are these things called COVID toes, where some people might have no other symptoms of COVID-19, but then they have these really weird, not ulcers, but this discoloration that forms on their toes. It's similar to what you would see from frostbite, or what's called Chilblains, which is a painful red inflammation, normally that comes with exposure to cold. And so we're having warm weather in much of the world right now. It's springtime in the northern hemisphere and fall time in the southern hemisphere. And yet we're seeing these things that are typical of the middle of winter. And so we're starting to see these just bizarre consequences to this new disease, this novel coronavirus. And so there could be viral replication going on in parts of the body that you're just not going to get from a nasal swab. And that makes it a real challenge to know if people are infected. Now, presumably, if someone has viral replication in a part of their body, let's say their toes or part of their body that's not respiratory, then at least maybe they're not at high risk of infecting other people. Because if their lungs are infected and they're respiring it out, then they can infect other people. But if their lungs are not infected and you do a nasal swab and you don't have any viral shedding, then at least you don't have to really worry about them infecting other people. You would just have to worry potentially about what's going on with them. Are they okay? with their other things. What we do know, some other sequelae that have been identified are that because it's an inflammatory reaction, a lot of times when you have system-wide inflammation, it increases the risk of causing a blood clot. So maybe potentially strokes and other things like that. And so we are seeing more of those associated with this disease. But these are still things that we're looking at. And so to get back to your question in terms of, so what was the exact question? I just went on this tangent. Can you say that again, Beck?
The question was about having a full body testing regimen around the country, and can we really be sure that it's safe to open, that we might already genuinely be at that point without knowing it? Meaning, you know, it's interesting, all these antibody tests that are being done. Some interesting news came out of New York City this week, and it just goes back to, how do we really know what our state is, you know, the current condition of our country, if we don't have full testing?
So the first set of answers I just gave was talking about specific people, some symptoms in specific people. If we look at the population level, then you can ask a different sort of question. Are the rate of infections increasing? And so, you know, going back to what we had said in previous weeks, looking at this R number in terms of the number of people spreading, if you assume that one person infects 3 other people on average, so if we assume that the R value was 3, then you'd see a rate of infection that was rapidly growing. And so it would be this exponential curve rapidly growing. If you are in a situation like we're in, where at least in the Northeast, where the number of infections are going down and it's no longer an exponential growth, then that means that you can, then the implicit assumption is that the R value is no longer 3. The R value is less than 3, and so that means that the number number of cases are not exponentially growing. I think that the guidelines have said that if your state if you have a decreasing number of new infections in the state over a 14-day period, then that means that you have a handle on it, and that would be a good indication that the state could start to open again. In that case, then getting back to this idea of resetting the clock, then once we reopen in that scenario, not the states that are reopening early, but in states that really have demonstrated decrease in virus, and so I mean, maybe some of the states we haven't really talked about that right now yet. But if there's a demonstrated low prevalence of the virus, then you can be more confident that it's going to be safer to go out and about, particularly if we still maintain social distancing. And so that this is the best indicator that we have. That's enough on that.
One more question though on that.
Okay, oh please.
Before we let you go from that. So now we see that a number of states are reopening. And so Deborah Weissletter mentions we're seeing in Georgia, there are now 1,000 new cases today, and now it's open. So where do we go from there?
Yeah, so Georgia, that was, I was pushing away from that question, but let's talk about it. I didn't really prepare many slides. No, but that's good. It's a really, really important point. So Georgia, so there's basically 2 scenarios that can happen on the short term when you reopen. Just because it's a novel virus, so no one is immune yet who hasn't been infected is the assumption that everyone's going on. And so what this means is that either you reopen and then you start getting a lot of virus again. So then the curve in that region is no longer flat. The curve will start to grow exponentially again. And so then the reasoning is, okay, well then if you don't have sufficient test and trace in place, there's nothing to prevent it from just exponentially growing again. So then in those places, as soon as it starts exponentially growing, they'll put another lockdown on over there. And then at some point it'll continue growing within the households like we saw over here in the Northeast. And it'll continue growing for a while, transmitting inside the household. And then at some point they'll have a flattened curve. And so that seems to be what the trajectory of Georgia would be on if they don't have sufficient test and trace in place. And if their infections are increasing, then that is a really good indicator that they do not have it under control. Because if test and trace were effective, then for every single one of those 1,000 new infections, they would have a team of public health workers tracing where each one of those people had been over the last week, who they might have gotten it from, who they might have given it to, and then they would need to provide tests to the whole community of people that those 1,000 people might have been exposed to. And that requires an army of testing and tracing. And so Georgia is unlikely to currently have that right now, which means that if it's out of control, then it's just going to be on this curve. But alternatively, if we do things the way we'd like to do it in the Northeast, what we're talking about in New Jersey, New York is a controlled opening where you have a minimal number of people infected for everyone. I'll go back to this slide. For every one of these people that are infected, you immediately trigger the contact tracers. And so once you've tested them as positive, then you immediately contact all their surrounding people who they might have gotten in contact with, and you trace them back to see who would have infected them. And so if you can be 100% sure of of each of these paths, who they were on, then you could prevent the growth, because if you contact all these people, you will have tested them and identified that they might have been viremic before they even had a chance, because of the incubation period, before they even had a chance to infect anyone else. So then you just cut it off. So each branch would be cut off, and then you don't end up in a situation where you have all of these branches spreading out of control. And so in Georgia, if they don't have it in a controlled environment, then there's nothing to stop this out of control growth rate. The one other thing I'm going to say about Georgia is they do have a large minority population. And so let's talk about this for a second. Imagine if there was a virus that targeted only minorities. So say it only targeted Blacks, or only targeted Jews, or only targeted some subset of the population, and it was going out of control. My perspective is, as Americans, we'd have an opportunity to help those minorities in our country, because we would want them to do the same for us. And it's the golden rule. Every religion has this idea of the golden rule, and every sense of ethics has this idea: do unto others as you would have them do unto you. And so if there's a subset of the population that's at highest risk, then we should protect them as if we are protecting ourselves. Already we know that people who are at higher ages, like 65 and over, and the older you get, are at higher risk. Also, people with some comorbidities are at higher risk. But what we're finding now, based on New York City in the United States and some other areas, is that African Americans are also getting slammed by this. To a lesser degree, Latinos, but Latinos also in terms of some of the hospitalization rates and the death rates. And so in Georgia, they have a larger population of minorities than other areas do, than some other areas in the country. And so they're at higher risk now. And so almost there's like a racial element in terms of this decision to open up, where, it's a continuing bias almost in terms of their willingness to put a subset of their population at risk. And that is something that it needs to be part of this conversation. And so there you go. Now it's part of the conversation.
Thanks, Glenn. Thanks for talking to us about Georgia. It'll be interesting to watch that state closely this week and the coming weeks for sure, and as well as other states that are opening up. Can you talk to us in a prior conversation? You spoke about the BCG vaccine for tuberculosis, and you mentioned previously that it was being investigated for use in COVID-19. Do we have any additional information on that?
Yeah, let me take a look. Yes, so basically, I think this was it. Yeah, the BCG vaccine. All right. So basically, early on in the, whoops, give me 1 second. Okay. So early on in the epidemic, in the pandemic, one of the early things that we found was that there seemed to be variation around the world in terms of the outbreak, how fast it was spreading. And one of the things that we saw were that countries that had vaccination programs in place for this tuberculosis vaccine, so the BCG vaccine, were not, their outbreaks were not happening as fast as in other countries. There seemed to be some sort of protective effect in countries that had this vaccination program, the universal vaccination program among infants. And so the vaccination program was most likely a marker so that countries that needed a universal vaccination program typically had more common prevalence of tuberculosis and some of these other respiratory diseases that were just endemic to those areas. And so even if they didn't get the vaccine, they were at higher risk of being exposed to tuberculosis and stuff, and that would have potentially protected them. One thing that we found in the BCG vaccine over time, or again, the countries with the policy for the BCG vaccine, which could be a proxy, is that it seems to be protective against other viruses and other pathogens. The BCG, it's a bacteria. It seems to be protective against other things, because most vaccines, or let's say every other vaccine that we've prepared currently, are based on antibodies. Antibodies are very specific. So even within the flu, you might have different vaccines every year. That's why you have to get revaccinated, because of the mutations in flu. The antibodies are so specific that flu from a couple years ago will have mutated enough that your antibodies that you might have created for that will no longer help you with the new mutations. What's unique about the BCG vaccine is that it seems that it's stimulating the part of the immune system that doesn't rely on the antibodies, just it's a general immune response. And so because of this, it's been investigated for other respiratory illnesses, and researchers have started a lot of clinical trials looking at this. The polio vaccine is also being investigated now for similar reasons. There was an extremely strong correlation at the beginning. 90% of countries with this vaccination policy, or let's say countries with this vaccination policy, had 90% less of coronavirus cases or COVID-19 cases, and had less mortality. Now the bad news. So as we started following these same countries over time, we realized that it was just correlation, not causation. So there may still be some clinical benefit. It's being investigated in clinical trials now, but we're looking at those same countries that did not have the early spread, and now the virus is spreading at higher rates there. So the correlation has gone down. We don't know if there's a benefit. There could still be a clinical benefit. One thing that we know is that in terms of the memory of the body from the vaccine, it doesn't last for a long time. Some vaccines might last a few years. Some vaccines might last decades in terms of the ability that they have. One thing we know from the BCG vaccine is that if you are tested with a skin prick test later in life to see if you've ever had tuberculosis, you typically still get a positive result in your skin decades later. So there might be some memory that's still continuing, but we don't know in terms of this general immune response. And right now, the further follow-up has not been really good in terms of looking at, we would have hoped that it would have been a much stronger correlation over time, but it's just the opposite. So that's not good. The clinical trials are ongoing, so we might find out more, but it's unfortunate. All right, back to you.
Thank you. Going back to test and trace, you mentioned test and trace a lot. I know Bloomberg has been heavily involved in funding a big test and trace program. Can you explain to us that technique versus other interventions, and what other interventions are there if we can't fully rely on test and trace because of the army that's needed in shutting down each one of those segments?
Yeah, so I didn't have time to do a better graphic than this. I just grabbed this from the web. But basically, test and trace on its own, like, so let's put it this way. If you had $50 billion and you could spend it any way that you wanted, what would be the most effective way to stop the outbreak of the coronavirus. And so based on this, you could say, well, do you invest that $50 billion in trying to create new vaccines? Or do you work on trying to create new treatments? Or do you work on test and trace? And test and trace is actually, for a lot of people, one of the surprising best choices as a possible solution. Because if you can identify these people and then stop the branches, then you never get into a scenario where you have so many people that are infected. So you can literally just be playing whack-a-mole for months, catching the branches, and then just stopping it. And so the alternative is, say you don't test and trace, then the alternative is when each of these new people gets infected, then you need to treat them. At that point, that's how a treatment would work, is that the people would still get infected, it would still spread, but that at every point you would treat them. Potentially the treatment might stop some people from spreading it if it's an antiviral, or it could prevent them from having the severe version of the disease where they would die. So maybe it would just be a self-limited disease where they're under treatment and they're sick in bed for a week or two, but they don't die and they recover, which is a big problem, but it's not a mortal problem. And so that's how treatment would play out, where it could either, depending if it's an antiviral that was easy to take, so not an infusion drug like the one we talked about earlier, but rather a pill that you would just pop. That is different than in terms of how it would play out in terms of the growth. And alternatively, a vaccine, the way that would work is that you'd vaccinate all the people in the population. So presumably, it would be harder for these people to get infected from this. So then you wouldn't get as many people who get infected. Typically, vaccines are not hugely effective. So for instance, the flu vaccine might only be 40% to 60% effective each year. And that's one of the reasons you need to vaccinate so many people, because in order to get this herd immunity, if it's only 40 to 60% effective, then you need to get way more people vaccinated than you would otherwise just to get that level up to what the revealed herd immunity would need to be. So these are basically the three approaches: test and trace, vaccination, and treatment. The benefit of test and trace is that it gives you clear visibility into what's going on. The burden is, and this is a real burden in a free society, it forces us to identify people who are infected and who they might have infected. So if people don't want to be tested because they're anti-vaxxers, or if people don't want to get tested because it's against their religious belief, or if they don't want to get tested, here's some scenarios. What if someone's an illegal immigrant and they're afraid that if they get tested or get identified by our political system, that the risk of being exported from our country is worse than potentially just getting the disease and then just getting better and not dying from it. And so there might be a lot of people who are motivated to not get tested, so they won't let people test them. There's a lot of people in society like that. People who might have an open arrest warrant for them. People who might have, maybe they're a low income person who's living paycheck to paycheck, and if they are identified as having COVID-19, they won't be able to go to work for a month. They'll have to quarantine at home. They will be highly motivated for no one to know if they have the illness, for a lot of people like that. Let's say incentivized, not motivated, incentivized for people not to know. And so there is going to be a lot of incentivization for people not to get tested. And that is really problematic in a free society in terms of identifying these people. Because if you have, let's say, one person here who refuses to get tested, then on average now you have 3 new people who have been infected. And typically communities tend to know other people who are in the same boat as them. And so if you have this one person who is infected, who was not diagnosed because they refused to be tested, then now, in addition to this one person who is infected, you potentially have the 3 others have now potentially infected 3 others each. And so you have this blooming of infection. And that is really hard to address with test and trace unless you have some sort of mandatory program in place. And this is problematic. However, if you have a program in place where you can start to find this, then a effective test and trace program, maybe you'll find, say it was this person over here who was first infected and refused to be tested. These 3 people refused to be tested, or you didn't even know to test them because you didn't know, you weren't aware of the branch. Then maybe this person was tested and this person was tested. You could ask them where they might have been, and then you could trace it back potentially. So then you could still lock them down, lock the branches down, but it would take you longer and more people are potentially put at risk as a result of this initial person and these potential 3 people not being aware or refusing to be tested. So it's still possible, but it makes work much harder to do test and trace. And then again, test and trace require, all of these require, any scenario that we do requires that once it gets out of control, that we have a universal lockdown again, like we just had. And that's the only way to address it. So what essentially, if we can control it, here's some scenarios I'll put up. There have been a lot of forecasts, a lot of predictive models that have looked at different scenarios. One scenario that people are looking at is peaks and valleys. So similar to what we have here, you have uncontrolled exponential growth. You do lockdown somewhere like early on, then it's all just household growth over the period, and then because of the lockdown, it comes down. So similar to maybe we're like over here now in our lockdown, or getting over here. At some point, maybe we'll reopen. If test and trace is not sufficient, then we'll have exponential growth again, or some regions will have exponential growth, and a lockdown will be required again. And so you might just have ups and downs until we have more effective vaccination programs or more effective test and trace in place. Alternatively is this 3rd scenario where they call it a slow burn. This would be where we have extremely effective test and trace, where we had our first uptake that we had, this first uncontrolled growth. Then it goes down, you have an effective program in place. So maybe you have little outbreaks in different places, but as soon as that happens, maybe you just lock down the local area, or you just do increased testing and tracing. And so you get a handle on it if you have a strong enough army of public health workers who can test and trace all the different people and the branches of people who might have been infected. But then the final scenario is a fall peak where it just goes out of control. So we're expecting that things are going to get really bad in the fall. And the primary reason for that is that first it's going to overlap with the flu. And so we're going to have normal flu deaths, and then we're going to have the COVID-19 flu deaths on top of that. And then 2, there might be a little bit of weariness in doing lockdown anymore. In the Northeast, we've been hit really hard. And so because of this fear that's probably in a lot of the people, there might be more of a willingness to accept the lockdown. But in much of the country where there has not been as much death and sickness, they might not be as motivated to lock down. And so that would expect us to have a much bigger peak in the fall. And that's problematic. And so that's going to just require more lockdowns as this approaches. The one other thing associated with that is, so one question that's come up is, how does COVID-19 mortality compare to influenza mortality? So the key concept here are confirmed deaths versus the assumed number of total deaths. So when we talk about flu, you might have heard in the news that the flu deaths, that the flu kills 0.1% of people who are infected. The 0.1% number actually is a case fatality rate. That 0.1% number would be related to the COVID-19 case fatality rate, which is still assumed to be around 3% plus or minus, order of magnitude 3%. So 3% COVID-19 to 0.1% for flu. Another way of saying this is that flu, we might have heard maybe up to 70,000 people might have died in a given year, but the actual number of confirmed influenza cases are much smaller. We extrapolate out to the population level because the way people die from flu are all sorts of ways. Maybe people have a heart attack, and then they die from the heart attack, but really it was the flu that triggered the heart attack. Or maybe they died from a stroke, but really it was the flu that triggered the stroke. And so, or pneumonia or other things. And so the cause of death on the death certificate might say heart attack, or it might say pneumonia, but really the underlying trigger was the flu. So in terms of confirmed flu, they're actually not a lot. So for instance, in the most difficult flu season that we've had since 2013, it didn't even hit 20,000 deaths in terms of confirmed deaths each year. And this was over the entire flu season, so that 1 year period. Whereas in the 2 to 3 months now for COVID-19, we've had over 60,000 confirmed deaths. Another way of looking at this is, of extrapolating, is this idea of excess mortality. Because it's really hard. You can imagine being a physician right now who's treating these patients is really, really hard. There's so many, it's overwhelming. And so if someone dies from COVID, from whatever cause, you don't want to waste any more time on the dead body. You want to go and help as many people who are still living to survive. And so we don't typically test. There's a limited number of tests still to test for the coronavirus and for the antibodies. So you wouldn't even want to waste your tests on the dead bodies. You'd want to put them on people who are living and who could potentially be helped by being tested. And so as a result, we don't know all of the cases that actually died from COVID-19. And so one way to figure out what the total number could be, rather than just the confirmed number, is to look at excess mortality. So over the year, there's this thing called all-cause mortality. And another way of talking about this is every possible way that people died. So if they died in a car accident, if they died of a drug overdose, if they died of a heart attack, a stroke, any way that they died, when you look at this over time, it's pretty stable. There are some seasonal changes that occur, but generally it's stable from year to year to year. And so as a result, that's one way for the flu that you would see on a flu, when you look at the flu, you could see, okay, well, if the all-cause mortality from previous years looks like one thing, and then you compare a spike that you see in terms of excess mortality, so additional mortality outside of the regular all-cause mortality, then you could assume that all of those extra deaths were associated to this acute event that happened. So either the flu, or in this case, coronavirus that you're looking at. So what we're looking at here is that even though, so you have these excess deaths, some portion of the excess deaths are from confirmed coronavirus deaths, but then you have all of these additional excess deaths without any idea of where they came from. And because you can look back the previous 5 or 10 years in terms of deaths that occurred in March, April, May, then you see, okay, well, we never really had the spike before. What could explain it? And so the clear explanation is the epidemic that we're going through. And so you can assume that these are all coronavirus associated deaths. And so this is a really common type of evaluation that epidemiologists do, comparing excess mortality versus all-cause mortality, because it helps you fill in the gap of how many people actually died. And I forget what led to this question, but I will just stop there unless there are any follow-on questions here.
Well, I have a follow-up question to that. So you talk about the work of the epidemiologists in looking at this data and trying to analyze exactly what that data means. Where is the line between epidemiology as a science and public policy, which involves politics?
That is a really good question. And that's related to what we're looking at in Sweden. So different states, different countries are taking various approaches to dealing with the epidemic. And so there's inherently a policy component here. And policy and epidemiology actually go hand in hand. So the definition of epidemiology in the textbook is the study of the distribution, so how widespread and the distribution among populations the study of the distribution and the determinants. So what causes the disease, and what are some ways to prevent it, or what things exacerbate it? So what are the distribution and determinants of disease in human populations? And this also includes how that changes over time. So in terms of looking at forecasts, and it looks at what we can do to prevent it. So for instance, one thing that we can do is a pharmaceutical intervention. And a pharmaceutical intervention would be taking some sort of drug and either, say, a vaccine that would prevent something or a drug that would treat something. Those could be potential pharmaceutical interventions that would address the disease. But there's a ton of other types of interventions. So for instance, among people with psychiatric illness, where they might have anxiety or depression or other illnesses, frequently, so one type of intervention, therapeutic intervention that we've studied is talking with a therapist. And we found that talking with a therapist is an effective treatment for people with psychiatric illness. There's pharmaceutical interventions too, but even just talking is an intervention that's non-pharmaceutical. There are many non-pharmaceutical interventions in addition to that type of therapy. So for instance, you can use the same type of study designs in terms of looking at the impact of an intervention in terms of preventing or treating disease at a larger level too. So for instance, if we have a question about the value of keeping elementary schools closed or of opening them, say where only half of the students come into the school during a period of, say during 1 week, so that you can spread all the desks further away and have more social distancing, and then maybe alternate every other week in terms of which students work remotely and which come in. All of these are policy interventions, and all of them can be rigorously evaluated using epidemiology techniques, because it's an intervention, and so you're measuring the intervention and then you're measuring the outcomes. So you'd have different types of groups based on the intervention control groups, and as well as control groups. So then you can see, well, does it actually help to prevent the spread of the disease or other severe outcomes? And so every single one of these policies can be rigorously evaluated, and epidemiology is the science of evaluating the interventions to see if there's a protective effect. And so there's actually a strong overlap between epidemiology and policy science, public policy. And so there's a big interplay in terms of where that line is. Any intervention should be any ethical intervention should be within scope. It should be rigorously evaluated, and that process of rigorous evaluation is an epidemiology study, essentially.
Okay, thank you for clarifying those two terms and how they interplay. So we have another question from Sandy Rock. When, if ever, might we be certain that either having the antibodies or having known to have been infected once be a true indicator that individuals are safe from the infection?
Yeah, so that is a really tough question to answer right now, just because we still don't know a lot about the natural history of the disease. So, and because there's false positives and false negatives, but I'll get into that in a second. The first thing I would say is that if you have an antibody test that's positive, assuming it's a real positive and that there's real underlying disease and that the antibody was real, it wasn't a false positive, the antibody test alone doesn't tell you if you're still sick. So for instance, you could still be shedding virus without knowing it because you're asymptomatic. If you recall from previous a slide that I had presented, let me see if I can find it real quickly. To this one, this was a really early study. This is old at this point. But so one thing that you can see is that this bar, it's a very, very hard to see slide. I apologize for that. But so this bar up here is the period of time that people had symptoms. So this person had symptoms on this one. Each one of these is a different person. And we're looking at time. These are days on the bottom. And these graphs are all virus. So this person only had symptoms up until this point in time. The arrow is when they had antibodies, and yet you see they had all of this viral shedding for many days after the symptoms ended. So their symptoms ended here, and they felt totally fine. They were feeling back to normal, fully recovered, and yet they were still viral shedding. So if all we have is an antibody test, then all that tells us is that we have antibodies at this point. It doesn't tell us if we've stopped shedding virus yet. So we could still be sick, and that's problematic. The other thing is the reactivation and reinfection question is still an open question. There have been a lot of people in Korea, in China, in other places where it's been investigated, beginning in the United States as well, who have had clear clinical disease. So we knew for sure that they had COVID-19. Then they tested negative twice in 2 days in a row, which is still the standard in terms of identifying when they've cleared the virus. So they had 2 virus tests 2 days in a row, and they became negative. But then they were tested maybe a couple weeks later, and they had a positive virus test again. This has happened quite a lot. And so South Korea just reported a few days ago that the people that they went back and looked at were false positives. I haven't been able to identify a study which is dug into really evaluating this with more rigor. It was just reported by the Korean CDC. So hopefully that's the case, but it's hard to see, there's different levels of rigor that you see around the world. There's different levels. The devil is always in the details of looking at methods. And so unless we could really see whether they just assume that it's a negative, that it was a false positive, or whether there was actually clearer evidence where they actually took the patients back in and were looking at other indicators of active infection, I haven't been able to determine that yet. So right now it's still an open question, at least for me. But we'll see. Hopefully in the next week or so, there'll be more details that are released. The other thing, I had the opportunity to sit on a panel this past week at Novartis, where I work. And again, all my views are my own. Nothing represents Novartis. But on this panel, we were discussing the similarities between the HIV epidemic and the COVID-19 epidemic. And one of the women on the panel shared that there's a support group for the portion of people around the world who continue to have symptoms from COVID-19 for weeks. So for a lot of people, the length of the symptoms themselves, regardless of the RNA shedding, the length of the symptoms themselves might only last for a week or two. But for some people, the symptoms themselves last far, far longer. And so this support group that her partner was in, it's around the world, it's English speaking only. So for instance, a lot of people who are infected in China early on, in South Korea earlier on, if they don't speak English, they're not part of this support group in general. And so we don't know how long the symptoms might be going on. Some of the reported symptoms have lasted for quite some time in China among a small minority of these patients. But in this English only speaking group, where we sort of started having these outbreaks many weeks after China got hit, the patient with the longest time that they've had symptoms that's still in the support group is 11 weeks. So there's still a lot we don't know about this disease, that some patients, obviously it's not everyone, it's just a tiny, tiny, tiny fraction, but some patients have symptoms from this disease for many weeks. I mean, so this patient who has continuing symptoms for 11 weeks, we don't know how much further in the future because we haven't gotten there yet. So this is still something that's developing that we'll have to see what this looks like. And so there's a lot of unknowns now still.
Well, speaking of support groups, I appreciate being part of this support group and the information that you share with us weekly. Thank you to everybody for sending in questions before and during, and I think we have time. Is that okay, Glenn, for one more question?
Yeah.
And so I guess we'll wrap up with one more question, but if you have questions during the week, please send them to me or send them to Glenn, and we'll make a queue. And can we assume that we're meeting up again next Sunday at 3 o'clock?
Sure, that
Okay.
sounds great.
Sounds good. So get some more wood for your fire there.
Yeah.
So our final question for today is, I know there's still so many unanswered questions, but there are so many of us who want to be able to reunite with grandparents, children, grandchildren, and so many people have been in isolation for so long. At what point can we reunite, even if it's at a distance?
Yeah, that's a really important question. So let me go to this slide. So right now, because we've been under lockdown, we've gone on this peak, and for a lot of us, the peaks are going down. So ideally, you'd want to go and have these visits still knowing that you could be infected. There could be an asymptomatic infection and you don't know it, especially the slides I just showed you where there's still viral shedding and potentially people could still be at risk of infecting others for weeks after. But the probability is the lowest right when we reopen. Obviously, some states, if they're reopening prematurely, they might be somewhere up here at higher risk. But presumably, when in the Northeast and other states and countries that are more aware of the underlying prevalence, right when we open the lockdown would be probably the best time to go and visit the parents and the grandparents and other people. Remembering though that you should probably do it in an open space where you still keep some social distancing and you still are aware that that there's still a potential for infection. So you wouldn't want to go, say, visit the grandparent in their house if you had potentially an asymptomatic version of the disease where you could still get them sick potentially. But as we've been under lockdown for so long, for the majority of people who get COVID-19, as far as we understand, maybe there's a week of incubation on average 5 days among people who become symptomatic. They'll become symptomatic in 5 days on average, some people up to 2 weeks. And then you'll have a period of the disease, or maybe you're symptomatic for 1 to 2 weeks. And then from that, you might still have some viral shedding after that for a little period of time. So maybe we're talking about a month. Then you assume if you had a month of that disease, that someone in that household might have become infected from the original one. So then you extend it out. If our total lockdown has now been 2 months or more, then hopefully that was enough time for it to burn through the household that initial patient might have been in. So hopefully right now we're at a low period where there's still been, remember, a lot of people have not been on lockdown during this period, even in the highest hit states like New York City, New Jersey, in the Northeast United States. There are people who are still going and working at the Amazon warehouses. The Postal Service has still been active. The food distribution service, some of it's shut down, but a lot of it's still been active. And so there's still a lot of people who have been leaving and going to work every day and interacting. And so the spread is still going on. But this is the best opportunity right when we open. The one thing though that I would do is that when the lockdown opens, there is probably going to be a rush of people that first week going supermarket shopping and going to all the stores and doing all their errands, and probably let them go to the stores that first week, then wait till it dies down a little bit and maybe go to the second week, and maybe there'll just be less people around. That first week is probably going to be a madhouse when we open up, and it's probably better to avoid large numbers of people still at that point. Social distancing is going to be so important. So, I mean, even going to a park might be a challenge. But if there's another area that you can go that's outside where you can hang out with the grandparents and maintain the social distancing, then that first week or two is really the ideal time to do that. And that's it for me for this week.
Well, we thank you. I speak on behalf of our audience, both current and those watching on YouTube. Thank you for joining us, and thank you, Glenn, for your insight. We really, really appreciate you taking us through this journey, and we look forward to being together again next Sunday at 3 o'clock.
Great. Thank you very much. Have a great week.
You too. Bye-bye.